many of you here, I am not an advanced endoscopist. I am an esophagologist, and I will say one of the greatest privileges that I have is when I get to partner with my advanced endoscopist and manage patients with achalasia, right? It is life-changing, and particularly when we think about how far we've come. In the 1600s was the first description of how we treated achalasia with a carved whalebone to treat what they referred to as a spasm of the cardia. And now we have this elegant procedure that has incredible outcomes, which is, of course, POEM. And the number one concern that I get from patients or referring providers is, what about the risk of reflux? Right? We know that the rates are reported up to 40%. Some of these can be pretty severe erosive esophagitis. And I think with this great privilege that we have of offering POEM, it's incumbent on us to have an obligation. So noblesse oblige is a French term that goes back that when you are in a state of power, that comes with great responsibility. I also like to think of Peter Parker when his uncle coined that quote. And so my partner at work is Dr. Abbas Femi. He's our advanced endoscopist that does POEM, and he takes this very seriously, right? I'm very fortunate that we get to review our patients with achalasia, discuss, are they at risk for reflux? Is this really a good POEM candidate? Because POEM is an amazing, amazing procedure, and we can minimize this risk of reflux and let our patients live a beautiful, long life without having to, trade one problem for another. So here at UCSD, our POEM program started about 7 years ago. Dr. Femi and I created it. And so for an academic POEM program, that's relatively young. And we had the opportunity to learn from a lot of our colleagues and their experiences. And the way we structured it was based on 3 tenets. Select the right patient, how should it be done endoscopically, and make sure that we have a very structured surveillance program. So I'm going to talk through this. And first of all, near and dear to my heart is selecting the right patient, right? So this is our Chicago classification of motor disorders. And there are some patterns that are just a slam dunk that, yes, POEM would maybe be a very good option for these patients. Type 1 or type 2 achalasia, POEM, amongst others, like Heller myotomy, pneumatic dilation, are first-line treatment options. And now for type 3, POEM has really taken the place of being the first-line treatment option with the ability to extend the myotomy into the esophagus. But even when a patient has achalasia, we don't reflexively send them for POEM. There's a lot to consider. Of course, their comorbid profile, maybe their age. Do they have a hiatal hernia? It's uncommon, but patients with achalasia can have a hiatal hernia. What's their BMI to begin with? Are they okay staying on long-term anti-secretory therapy? So these are some considerations. But where things get murkier is this oblong shape. So these 3 patterns on manometry have an asterisk next to it, because just when you see it on manometry, that doesn't mean that they need to have their LES cut. Our motility lab here is open access, and so this is a patient that had a manometry done for dysphagia. And as you can see, their lower esophageal sphincter is relaxing okay, but their swallow's premature. That's what that horizontal white bar is representing. The distal latency is less than 4.5 seconds. So this was distal esophageal spasm, and on the barium there were tertiary contractions. So the patient came to me wanting to see if POEM was an option. Well, we always think about reflux in these patients, and the patient had a 96-hour wireless pH, and they had profound reflux, a high amount of acid exposure. Patient really wanted a POEM. They went elsewhere and then came back 2 years later with worsening symptoms. Post-POEM, they had severe esophagitis, so they traded non-erosive reflux disease for erosive esophagitis after POEM, when this was really GERD with a spastic reactive pattern. Another patient was referred for consideration of POEM. So here what we see is that the LES is maybe relaxing okay. There's a high contractile focus. That distal contractile integral is over 8,000, and there's that repetitive prolonged contraction, which is that jackhammer pattern. And this is hypercontractile esophagus. Well, there's a reason why in Chicago classification we made the protocol so overbearing, because when you move the patient to the upright position, you now see that they actually have a hiatal hernia. There's a separation between the lower esophageal sphincter and the crural diaphragm. And then when you do a provocation, after they drink this beverage, they have a contraction, the LES is profoundly relaxed, and then the esophagus shortens and they have a transient LES relaxation. This patient has GERD, they should not get a POEM for this hypercontractile pattern. And what I'm presenting is not new news at all. In the 1960s, they used to conduct these elegant studies. So patients with heartburn, control patients, would get acid provocation and simultaneous manometry. Almost all patients developed spasm or hypercontractility in response to acid. So acid can cause a spastic reactive pattern. Dusty Carlson and the Northwestern group showed this recently. Patients had undergone manometry, and then they also had a flip done. And if you just focus on the lavender color, so those are the patients with the spasm or hypercontractile esophagus, you can see it's a mixed bag on flip, and actually most of them have spastic reactive pattern. So bottom line is that when you see this pattern on manometry, don't reflexively move to POEM. Think about reflux. And for us, we will always do reflux monitoring for these patients before even considering that. Same story for EGJ outflow obstruction. This is a problematic pattern on manometry. Right, so the concept of EGJ outflow obstruction is meant to represent the LES is not relaxing, but it doesn't quite meet criteria for achalasia. But that has to be in a patient without stricture, angulation, making sure that that catheter is not angulated, leading to artifact. Once you actually follow the Chicago classification and ensure they have a true outflow obstruction, less than 10% of those that you thought might have had outflow obstruction actually meet criteria. So bottom line is be really thoughtful. Don't just follow a manometric pattern. And then the second thing is when we do decide to do POEM, what are endoscopic techniques that could perhaps mitigate that risk of reflux? Now, I'm not an advanced endoscopist. I'm talking to the experts in the room. But some things I've learned and what's in the literature is, does the thickness of the myotomy make a difference? And there's mixed data on that in systematic review and meta-analysis. Some suggest that there can be reduced esophagitis with just a circular myotomy. Also, what I understand from my endoscopy colleagues is that sometimes that's not under our control completely, and that can spontaneously convert into a full thickness. How about orientation? Does it matter if we take an anterior or posterior orientation? Originally, when POEM came out, it was mostly anterior. And the studies show that there's not really a significant difference in terms of outcome or post-POEM reflux. A lot of it is up to the endoscopist preference or the patient's surgical history and anatomy. But the one that does seem to make a difference is the length of the myotomy. And really, the movement now has gone towards a shorter myotomy. The clinical success is similar for both short and standard. Procedure time is definitely shorter with the short myotomy, and the data does show less reflux and less esophagitis. Another exciting thing is utilizing tools during the POEM and afterwards. So this is FLIP, right, which measures the impedance and the distensibility across the esophagogastric junction. And there have been a number of studies looking at, well, could we tailor the POEM to measurements on the FLIP? And what most of them suggest is that there's a sweet spot, making sure that the myotomy is complete, but also maintaining that integrity of the anti-reflux barrier, having a distensibility index somewhere around 3 to 5. So this is a young patient. She was 29 when she came to us with type 2 achalasia, and she wanted a POEM. And I saw her a year after her POEM, and the term that we use at UC San Diego is that Dr. Femi Goldilocksed it. Because a year later on her endoflip, she had a distensibility index of 4.3, diameter of 16, and then on reflux monitoring, no GERD. So this is, can really help you tailor the POEM in real time and then also follow afterwards. Okay. For anyone that's doing POEM, I really recommend that you have a surveillance program, whether that's with your general GI colleagues, your APP, but the journey doesn't end right at the POEM, and there's a lot that we do and we follow, such as optimizing their anti-secretory therapy, their weight, and then following for potential complications afterwards. There's a really nice document. It was championed by Dennis Yang. It was the North American Consensus, which really goes from pre to post-POEM considerations. The ones related to post-POEM GERD really emphasize that patients should be on anti-secretory therapy after the POEM. They should get an endoscopy and reflux monitoring. And if they're doing well at follow-up, you can consider de-escalating their therapy. There's also some interesting data, and we've had this observation too, that perhaps at 12 months after POEM, there's remodeling at that lower esophageal sphincter, and so that risk of reflux may actually reduce in the long term. And hopefully we'll learn more about this. But the bottom line is that patients should be on optimized anti-secretory therapy, and it breaks my heart when I see patients that come in on pantoprazole 20. So this applies to any reflux management. All PPIs are not the same. I see the fellows smiling because if there's one thing that we take away in our clinic, this is it, right? Omeprazole's in the middle of potency. Pantoprazole's the weakest. But our second generation PPIs, rabeprazole, esomeprazole, dexlansoprazole, have greater intragastric pH suppression, less metabolism through CYP2C19. And so if you have patients that have undergone POEM, you want to give them the best chance at preventing reflux. Make sure they're taking it before meals, it's double dose, and then switch them, if the payer allows it, switch them to a more potent acid suppression agent. And some of our patients are on PCABs. We have a handful that are doing really well after POEM on PCABs. So remember, vonoprazan now is a potassium competitive acid blocker that's approved in the US. And these are not PPIs. They work on the proton pumps, but they're active prodrugs. So they bind active and inactive pumps. It's a game changer because they don't need to be dosed around meals, so it's much easier for patients. And they're rapid on onset, so after the first dose, they can achieve acid suppression. The landmark study to be aware of is this randomized trial that was published in Gastro. Erosive esophagitis patients were randomized to vonoprazan or lansoprazole. And the key takeaways is that vonoprazan is not inferior to lansoprazole, but in fact has a greater absolute reduction in terms of healing and maintaining healing, especially for your patients with very severe esophagitis. Another really important part of our surveillance program is weight management. This project was championed by our resident Nick Lee, who's now a GI fellow at USC. And what we noticed is after POEM, our patients love to eat. And naturally, they gain weight, which is wonderful, but sometimes they're gaining weight in excess. And we noted that those that gain 10% greater, it's associated with reflux. But this is something that we can actually very much help our patients control. So in our program, our APP follows the patients and counsels them on lifestyle and weight goals, and it's been very effective to minimize the excess weight gain and reflux. And then the last thing I'll just touch on briefly, because we have the world's expert, Dr. Chang, that's going to be talking to us about endoscopic anti-reflux interventions. But this question comes up, can patients get a fundoplication or a TIF after POEM? And there have been a few studies looking at this. They show that fundoplication and TIF are feasible. Patients are able to get off PPIs, their quality of life is improved. Sometimes the acid exposure time may not significantly change. There may not necessarily be a reduction in erosive esophagitis, some mixed data, but it is feasible. I think the bottom line is not all patients need it. As we mentioned, at 12 months, the risk of reflux may actually decrease, but for those that can't stay on long-term acid suppression or those that definitely have GERD or at risk of severe GERD, it's a great option. In terms of whether TIF at the time of poem is an option, so some studies have been done, presented at DDW, and the jury's still out. This is from the authors. They state that it can be offered as a part of clinical trials, but it's still investigational. Because there may be risk of increased complications at the time. I think we need more data, but it's a very exciting prospect. So coming back to how can we really optimize this for our patients to reduce post-poem reflux? First of all, make sure you have the right patient, that they have an indication for LES myotomy. And most of the time when you see spasm or outflow obstruction, it's not real. It's more a reactive process to something else. Endoscopic techniques, consider a shorter myotomy, avoid the sling fibers if possible, maybe a partial thickness, and then utilize physiologic tools like FLIP to help guide you during the poem. And then have a structured surveillance program optimizing anti-secretory therapy, weight management, and monitoring for post-poem complications. And I'm very excited to announce that we are part of the pre-MEDIA trial, which is an NIH U01 study, a multi-center study in the States, and we're enrolling patients with achalasia and trying to better understand who is at risk for reflux, what are outcomes following poems. So I think that's going to lend to some really important data in the future. And so with that, I'll end. Thank you again for inviting me. It's such an honor. And I'll move on to the next speaker. Thank you.